each one is going to introduce themselves, and then they each have 5 minutes, and there's going to be hooks and all kinds of things trying to keep them on time. And then we're going to really open it up for questions and answers. So people should be within line of sight of either myself or Timmy so that we can engage you. I'm Dr. Sophia Chang. I am an internist by training and practice, and I'm currently the Chief Clinical Innovation Officer. And my job really is to say, it's all great to have these wonderful new ideas and technologies, but how do we really get them into practice and make them part of a clinical delivery system? And that's my job.
So we'll go from right to left. I'm Fish. I've been in the digital health industry for 6-7 years. I'm leading a startup that we're just getting out of stealth mode, so you're going to hear the story for the first time today. Before that, Samsung, Apple, Nokia, and 2 other startups.
Hello everyone, thanks for coming today. Kevin Jones from Samsung. I lead the business development and strategy team for Samsung Electronics, mostly based out of Dallas and United Airlines.
Good afternoon, Alex Go, co-founder and CEO of LiveWell Health. We offer a home and community-based services solution, which you'll hear more later.
Hi everyone, I'm Vincent Sirhan. I'm with Giuseppe Health. I'm the Executive Vice President of Business Development, and we look to bridge community services with the payer providers and make it easier for the community members.
Hi, I'm Dennis Robbins. I work across a number of sectors dealing with health and healthy communities and trying to change the paradigm from a model based on dealing with episodes of unhealth to health, and also work with moving away from a concept of patient almost entirely back to the person. And in so doing, I'm on the boards of several companies that help with new startups and the Clinton Foundation, the Army, and the Navy, and a whole bunch of stuff.
Okay, so it's easier to spend. I have 3 kids, and trying to do dual careers, 3 very young kids. You realize when you look at your experience at home that healthcare at home still has a long way to go before it can be an experience that we desire, and that's something that even for me, a professional in the industry, something I've seen multiple times. And when I started looking at it, I realized there is an interesting opportunity that touches to the core of what this panel is about, and what some people asked earlier about remote communities. And this is about bringing together all of the different innovations in healthcare into one consumer experience at home. It's an experience that brings together the innovations in sensors, innovations in supplies, and innovations in know-how. We all know the WebMDs and the MD Live and the American Well. They're all know-how innovations. But they usually don't talk with all the supplies and the medications and the tools that you need. And the sensors are completely separate. So how do we bring it to create the right experience for the user? Be it the user like a lot of us with young kids, or be it the user in a remote town in the US, and somebody mentioned some of their work in Pennsylvania, or be it a user in remote countries, as some of the people active in HDF, like Dr. Choi, have been active in going and helping. So that led us to create Gale.
Nightingale here. How may I help you?
Reinventing the first aid kit. Gale is the world's first smart first aid kit, bringing together health know-how, the expertise of medical providers, as well as the latest medical sensors and first aid supplies. About 10 square inches, it's portable and can easily be carried around the house or taken outdoors. The extras drawer is home for the latest health sensors such as blood pressure, oxygen, heart rate, glucose, or more advanced sensors. These are always charged and always ready to be used. A single button can assist in finding help, from family members, medical professionals, or even 911. Powered by a cellular tablet, Gale offers an interactive first aid guide. The sensors can easily be utilized and the information shared with medical providers, and video calls with medical experts are a touch away. Gale is more than a first aid kit. It's a smart, portable, all-in-one health center that every household and office should have.
So that's basically Gale and what we've been working on in the last half a year. A couple of things to note. This is not about us trying to do all of it ourselves. It's the opposite. It's about us trying to bring the best in the ecosystem together, be it the best sensors, the best application, the best services, and put them on. The application of where it can go, we see some very different opportunities, and part of the reason we're here today is we want to hear feedback from the audience and from the industry leaders about the different market opportunities. We started it looking really at parents with young kids. One of the things that caused it was me being with the kids in a small remote town in Mexico on vacation and getting a group attack and spending the night calling Kaiser back in the US. But very quickly after we started, we realized that, hey, this is something that a lot of companies would like to have in their kitchen. Not only at the first aid, but also when somebody needs to go and visit, to do a remote visit to the doctor, the sensors and everything else is in the unit ready to be used. And if once you use it, you need new supplies, you touch, and the supplies are being shipped to you. We saw opportunities with seniors, and we saw opportunities even in hospital discharge. And it touches really a lot of places on home and community. And that's where I'd like to get the help from the audience here and hearing and listening to their thoughts and reflections.
So hello everyone, Kevin Jones with Samsung. I have a few slides, but I'm not sure if they'll make it. I'll just introduce myself again briefly. I've been in digital health now at Samsung for about 4 years. I'm a technologist background with a real passion for healthcare and a really great opportunity that we're looking at, and I'll talk a little bit more about today at Samsung. When we look at the underserved, it's not just by income, it's not just by ethnicity, it's not just by any one of those single factors. If you look at perhaps the most underserved community in the United States is the senior market. So the elderly historically have been regarded as being afraid of technology, and really it's not so much that they're afraid of technology, it's really the burden on us as the technologists and the providers to make technology easy to use, to make it bulletproof, to make it usable in such a way where it genuinely impacts their quality of life. And if you look at some of the areas of technology that we're investing in, obviously at Samsung everyone knows that we're very involved in phones, tablets, consumer electronics. Wearables is a big focus for us as well. And you start thinking about aging in place, seniors, the desire for most senior folks, any of you with elderly parents know this, we're going through it, my wife and I ourselves, it's much better for that elderly parent to age in place, to be able to stay in their own home. What typically triggers a move to a care facility is a fall or some other event that where they fall, they break a hip, there's some other traumatic event, and that's typically the trigger for them to move into a senior care facility. So our objective of my team is that we're looking at introducing technologies to basically delay the point in time at which that person has to move into a care facility by 2, 3, 4, even 5 years. And if you look at we're all here today to improve outcomes, lower costs, and improve patient satisfaction ultimately. If you look at a real win for an elderly person, for them to stay in their home for another 5 years, the economics are just unbelievable. The cost of them staying in their own home and supported by ancillary technologies like wearables, like smart home devices, the cost savings for them to stay in their home is incredible. But also, more importantly perhaps than the cost, is the quality of life. As we all know, when seniors move into elder care facilities, that actually triggers tsunami of negative, a cascade of negative events. Depression sets in. They're more disconnected from the grandchildren. Typically, the family, it's more difficult for them to communicate with the friends and the life they had before they entered that facility. So that basically triggers this whole cascade of negative events, which of course then has ancillary spillovers to their overall health and quality of life. So if you look at patient satisfaction, again, the driving force from what we're doing in technology is putting easy-to-use technologies in place, whether it be wearable, whether it be tablets or smart home devices, that allows those senior citizens to stay in their homes longer. And I'll just mention there's a slide up here with a company we're working with called Breezy. Breezy is a UI UX company that we work with. It's obviously a Samsung device, but the core thing is that they're using technology that we've developed to introduce a tablet into the senior care market that's impossible for the senior to basically put in a state that they can't get back. We actually lock it down. It's essentially a term that we use in the tablet space called kiosk mode. So there's no way for that. I've given my mom, dozens of devices over the years, and usually by the time you're off the driveway, she's already put it in a mode where it's useless, right? She's already entered into, somehow got into a DOS prompt, has no idea what to do with it, so she throws it in the drawer. With this tablet UI UX, there's absolutely no way that the elderly person can actually get it out of a state that they can't just automatically hit the home button. And it's an incredible piece of technology in terms of usability. Seniors, of course, like this UI because it allows them to seamlessly communicate with friends, family, the grandchildren, and it's a portal for information and generally, keeping them more connected with the world, which does stave off depression and anxiety and ancillary negative effects. So that's my summary, sir.
And as we move to Alex and you bring up the next set of slides, so let me just reframe and make sure that we are aware that we're all talking about home and community-based systems. So what you've heard from the first two speakers is things that are a little bit more device-enabled and device and services. Now you're going to hear from two other speakers. We're going to talk a little bit more about some of the connections in particular outside of what we call our traditional healthcare delivery system, and how this loops back to what we were talking about earlier for the first panel is we really are talking about health. And so as many of you heard, whether you want to say that it's 99.9% of the time that people are actually having to manage their health as opposed to being engaged with the healthcare delivery system, or whether you want to talk about dealing with the whole person and family, these are all aspects of trying to get at that very nut that we're trying to crack.
Thank you, Sophia. That was an excellent segue. My name is Alex Go again with LiveWell. I'll start with a personal story, like many entrepreneurs. That is my family on the left side there, your right side. They had an ER visit, went to the excellent ER care, Dr. Copeland, by the way, through Kaiser. And then they came home, and bluntly, it was full-time caregiving. That was my story. And I found out that I was not the only one. There's over 40 million seniors living at home, independently at home. 1/3 live alone, 30% underserved. Right? When we started our venture 3 or 4 years ago, strong, as we all know, systems out in the market. However, many are paper-based or unsecured communication. And so what we did is we partnered with an organization called Eschaton Senior Living, based up here in Sacramento, where they had a holistic model of care where they not only offered in-home care services in the form of geriatric care, but also transportation, medications refill, all of the social determinants that typically define over 60% of health improvement. We built a custom platform on top of Salesforce using the Force.com developer kit, which included in-home rules-based geriatric care assessments, a custom secure portal to manage services as well as procure new services, whether it's the family caregiver or the senior themselves, a custom services registry where there are over 300 community providers, anywhere from gardeners to home care to transportation vendors, all in one secure cloud hosted by Salesforce. Next slide. So the punchline here is we've been partnered with Eschaton for the last 6 months on a home and community-based services pilot with a goal of measuring what are the value of social determinants of health. Great to share some of the preliminary outcomes from that pilot, which includes significant improvement in clinical outcomes, as you can see on the left side, which also includes excellent patient engagement scores, most proud of which includes they would recommend, every single participant would recommend it to their friends and neighbors, and that's really been the referral program with the pilot program. Improvement in what's known as a quality of life index, as well as the most interesting part from the payer perspective, many of which were willing to provide some level of co-payment for these services that are typically non-clinical based. On our side, one of the keynotes of the technology is about clinical satisfaction. And we initially started with a group that were technology averse, no surprise. But now we've got champions within the organization that's been spreading the news within the geriatric care staff. We did pre and post measurements of productivity, and what typically would take an 8-hour episode of care dropped down to less than an hour and a half. Significant staff productivity. And then now we're summing up some of the overall program ROI into a comprehensive paper to correlate that to some of the medical interventions. So again, it's Alex Gill with LiveWell if you want to stop by, and we'll be here today and tomorrow.
Nicely done, Alex. Leave Alex's slide up. There we go. So I'm Vincent Serrano with Giseki Health, and I got to Giseki, I've just joined them probably within the last 2 months, but I've been talking to the co-founder, Tushar Bashant, for a year and a half. We have the same background in bringing innovation to, for myself, it was Molina Healthcare. I worked with them for 8 years. I worked on the business side in the innovation department, bringing new ideas and trying to fight those ideas into the plans. And then switched to the technology side, to the IT side, to understand why we weren't getting adoption from our own IT folks. And so as someone else had brought up the question that I was speaking to, how do you bring those ideas in? And what I found as a gatekeeper was that you have to build relationships inside the plans. You have to build relationships not just with corporate, but with the individual plan. So for example, Molina, each of their plans were its own entity. So we would have a president there, we'd have a VP of healthcare services that would look at an idea of innovation like, where has it been? Why haven't we had this sooner? I've heard this in the marketplace and I've never seen it rolled out to us. So we could get a foothold there. So Tushar and myself, we actually put together a healthcare innovation conference a year and a half ago, where we brought a bunch of these siloed individuals together into Long Beach, Molina was kind enough to allow us to use one of their facilities, and discuss the ideas of innovation and how to bring better innovation and how to get out of the silos. So out of that has come Giseki. We looked at, both Tushar and myself, looked at the marketplace of where we can make the biggest impact of disruption and bring better ideas to the greatest number of people. And in doing that, Giseki, which means my responsibility in Japanese, it is one of the ideas is to go out to social services and bring those to the population from the aspect of where the health plan leaves off. Much like our friend here and what he was saying in one of his companies, and what we're doing is not only bringing it to the population, but we're also recording their feelings of how the care was provided, and then reporting that back, because we know the systems, we know Epic, and we know all the reporting systems and how to bring it back into, for example, where they have their system and make it register and then give reports out to people, which was always my thought when I was inside of the system, inside of a payer provider, that the greatest information wasn't getting disseminated. I'm sure you all know that just a few years ago we were actually bringing data into member files by PDF. Well, you know, the electronic health records actually helped that tremendously, but we're not that far off. So what we at GISECI look to do is help those social services, help them connect with the members, the patients, and then bring that data back to the health plan and give an accurate reporting and have everyone involved in it. So just a quick snapshot.
This is technology. I'm an old person. I'm not going to know how to do this. Okay. So this is my neighborhood. Since we're talking about the home and community, I live right next door to a place where the Navy SEALs have their training center. And so there's CBs and Corps of Engineers, whatever. So the CBs helped the neighbor build this fence from broken surfboards from people being out in the wilderness. Anyway. So I want to take a little different perspective. I want to talk about the person. In the earlier panel, Busy was, and Ron were talking about members. I don't like talking about members. I don't like talking about patients. I don't like talking about consumers, because the only default we ever always are is a person. And those 2 30-minute or maybe 15-minute sessions that I spend every year in my physician's office or in a health sort of situation do not constitute who I am. I never wake up in the morning and say, my gosh, what a beautiful day. I'm going to avoid illness and disease. I get up and say, what a beautiful day. There's things I'd like to do. I want to stay healthy, to do them well, to do them the best I can, to maximize it with endurance. I'm more concerned about readiness, resilience, endurance, hardiness, mindfulness, balance. I don't care about avoiding disease. I care about being healthy. So the reason I'm standing is I'm over age 65. And people, men over age 65, are the most at risk of chronic disease. And sitting is a new smoking. And so I stand when I can. John Madison will do it tomorrow as well. We stand, we don't sit. I don't want to become a victim to my schedule, to my work, or anything else. I want to do things to make a difference in my life as a person. Now, what's really interesting is we've talked about in the payer panel the tension between the system and the person. What we often forget is the community and the infrastructure of the community and its resources, whether it be informal resources, 211, faith-based, are amazing in terms of being able to make a difference, to provide an infrastructure to support us and to make and keep us healthy. Even if it's just peer influence, to nudge us and support us and to encourage us on the right path. I do want to mention, since everybody seems so excited about technology here, the IMS study. IMS looked at 130,000 healthcare apps. Health apps, my apologies, health apps. The average penetration of a health app that isn't done well, there are ones that do it well, beyond 6 months is 0.08. You need a platform, you need other things than just the app. John Madison will speak about a ecosystem. We need a platform of ecosystems, he thinks, to be able to do what he calls create a symphony, a behavioral symphony of wellness. And it's not just about baby boomers. I'm older. I'm a war baby. Who forgot about me? And by the way, when we're talking about the home, and this is on home and community, when you come into my home, I am not a patient. I'm a person in my home, and you better accommodate to my home. It's not about the patient. It's all about the person. Passive patients are neither attuned nor expected to change. Think about it. What is a patient? It's a patient subservient, wounded, vulnerable, passive, on unequal footing. How can you expect them to change anything? But you know, if it's meaningful enough to any of us, if it's important enough to any of us, if it matters, we can do anything. So talking about the patient rather than the person is a huge paradigmatic mistake. So we need to create strategies and environments and support systems, 24/7 continuous reminders. I was hoping the Microsoft fellow was going to talk about the importance of live analytics and AI to support changes in our lives, because you can promote any behavior. It's sustaining it that's a trick. That can make a difference in our life and add years to our life and life to our years. So what's interesting, if you go back to the ancient Greeks, Aristotle said that health is the mean between the extremes of self-indulgence and self-neglect. It's all about balance. Asian medicine got it right many, many, many years ago. So engagements about multiple sectors requires that we move beyond the vulnerable patient to the person. That's it for me. That's going to throw it open to questions, and I didn't even look, I have a minute left. It's yours.
Hi. So before I open it up to the audience, I think one of the things, and to one of Dennis's last themes, I think one of the huge challenges is, we have all alluded to the fact that in healthcare, making things change and making healthcare to be delivered differently or with a different mindset seems to be an almost overwhelming undertaking. And so I'd love to get each of the panelists to speak a little bit more towards how you think about your approach. How are you thinking about getting the stickiness or the adoption, or not just focusing on the bells and whistles of the technology, but how is it that we're really going to address the needs of those who you're trying to engage, and what are your thoughts on that? Who wants to start?
For us, I think you're asking a very good question, because I've seen too many companies who have a great idea in technology, but focusing too much on the technology side. One interesting secret that I learned when building new companies is trying to really, it works best if you are the customer. And in our case, we started this, and we started building Gale looking at us as the customer. As I mentioned earlier, looking at incidents where, going to the ER when I didn't have to, I've done that. And running out of supplies and having a crying baby and trying to take care of them, I've done that. Trying to Google and figure out how to deal with different types of rash with a 2-year-old crying and screaming Hail Mary and trying to figure out which website I prefer to trust and what they mean. I've done that. So really looking at the experiences we have and trying to solve them, and then trying to solve them with the least amount of dependencies on other companies, both from a payment perspective and not trying to rely when you start about the Humana and Kaiser, which are great companies. They talk very proudly about how they have innovation centers, but they're moving very fast in those innovation centers compared to Humana and Kaiser, but typically not the same pace that a startup would like to move. So don't depend on the big players. It's nice if it happens, but you can't really rely on it. And find a way to build a solution that's really you can envision yourself or somebody you're close to as the customer.
Thanks, Ron. So just quickly, I'll just comment. I mentioned earlier that a big focus for us is actually delaying the event that triggers someone to move from their home into a senior care facility. And technology can and is helping to do that. We actually rigorously validate that theory, 24 hours a day, 7 days a week, because technology, for technology's sake, in and of itself, as you mentioned, isn't going to solve the problem, right? So it has to be applicable, it has to be real, it has to be easy to use. And that's one of the reasons we're so focused on the UI, the user interface, if you will, how the device actually presents itself to the person, the patient. And of course, even then, even when and if an individual moves from their home to a senior care facility, we work a lot with some of the major senior care facilities in the country, and a percentage of the population at typically a care facility, it might be 10, 20, 30, 40% of those persons are still ambulatory and still able to engage socially, and wearables and technologies like that can help them do that. One of the things we do with a lot of our wearables, as you may know, is we actually have built-in GPS capabilities. So that gives you location tracking, geofencing, if you will, especially for the memory impaired folks. You can set the geofence to be 2 kilometers from the property, from the main center, for example, so that you don't lose people. Activity tracking is another one, but not just for the triathletes and the marathoners out running 26 miles a week. Actually, if I'm a senior person and I'm on the couch, and I'm stationary for more than 2-3 hours, or I'm sitting, for example, my activity tracking actually doesn't just track my steps, it just doesn't track how many miles I run, it actually prompts me, hey, Bozo, you've been on the couch for 3 hours, get up and walk. Maybe I just had knee surgery a week or 2 ago, but I need to get up and walk, I need to get up and move. We all know that the outcome of any medical procedure is greatly influenced. If you can get that person up, get them walking, get them outside even, I mean, it has a multiplier of beneficial effects. So we're using technology in that way to help make, I guess to ensure better outcomes.
When we looked at the market 3 years ago, we looked at Pioneer ACOs, if you remember those, when they first released. And as you all know, CMS is committed to shifting payments to a value or quality-based component, 90% of them, by 2018. And what we looked at were, we didn't feel like as an innovation company, we were going to go beat an Epic. That was not the intent. We looked at where the gaps were happening, and it was really around the care and the coordination side, number one. Number two, we saw the breadcrumbs around consumerism of healthcare and this Uberism of health starting to crop up. So we were trying to say, well, can we drive something innovative, yet define it such that the smallest equivalent of care, the bastion of care, the senior center, can afford it at $100 a month? Think about that. Can you build a solution that can support at $100 a month and dramatically scale it? Well, that's what we built. So when we were there to not replace care, we're there to augment the current infrastructure that is dying for enterprise class systems, but didn't have the $100 million checks to write to Epic.
We're going to pass on our responses to the audience, please. Questions?
Thank you. Steve Goldsmith from Guardian Halo in Menlo Park. We are developing a new operating system, if you will, that will integrate all wearable data for seniors who are aging in place. And we're looking for partners. Love to talk to you.
Question?
This has been a paid advertisement.
Alex, good to see you again. I wanted to ask, because I've sort of
Can you introduce yourself?
Sorry. My name is Dave Gilbert. I run a sensor company, a venture funded out of Nashville called Evermind. And I wanted to ask Alex, because I've watched your business grow, what interest are you getting, and how much interest is there in the care management part of your offering, as opposed to I believe, correct me if I'm wrong, but the way you initially got traction was to create these sort of senior living services and create a platform for sort of optimizing the sharing and logistics around those services, but now you're moving more into care management. Is that the future of your company, and what do you see, or do you see long-term care beginning to embrace those kinds of services? And what do you think the future of long-term care is in terms of being able to maybe even compete with SNFs and other sort of rehab centers for those additional kind of medical services, which, as you and I both know, traditionally they have eschewed?
That was not a planned question, by the way. For those of you that have known LiveWell for a while, we were active in the senior living sector, and we continue to be. We have folks like Brookdale Senior Living as a client, as an example, in Eschaton. We would always looked at senior living as an underserved market from an organizational level. Our heart had always been in post-acute care. We didn't feel like we would get traction. Dave, directly your question in the care management space, I will say the last 12 to 18 months since CMS has doubled down in some of their initiatives has really driven a lot of traditional integrated delivery networks that are bluntly on Epic or Cerner, and we're struggling to find meaningful tools to manage metrics and reporting come to our door. Simply because we were active there and we housed it on Salesforce as a secure HIPAA and scalable solution.
Well, quick follow-up. So we're talking subacute or post-acute?
Post-acute.
So in the home mostly now?
Yes, home-based, purely.
We'll go here and then to the front.
Hi, my name is Ella. I'm from Community Health Center Network. We're a consortium for 8 FQHCs in the East Bay. I'm wondering about the scalability for LiveWell for providers or vendors that may not be able to afford the Salesforce platform. And then I have one other question too for Vincent about, I mean, it sounds like this opportunity for the two of you to collaborate. Like, how does your company envision making system-wide change based on the information you gather about the availability of community resources?
So, good question. So the lowest hanging fruit is actually developing solutions specifically for staff members to use. We have a built-in solution that has 2 tiers of membership or enterprise licenses. Let's say your traditional $100 per month, you get a custom cloud up and running in less than 30 days, right? And if there are transactional users within your community that only need it once in a while or just look up or refer a provider or patient or person to a community-based resource, event, service provider, et cetera, they can pay as little as $3 to $5 a month for that given footprint. Our ROI model has shown that almost all of our integrated delivery patient provider clients have not even bothered passing down the cost because they can directly see the impact of operational savings.
Can I ask a follow-up question? How do you keep your information about community resources current? Like, who loads that in? And are there algorithms to lock the staff person for like?
Alex, repeat the question.
Yes, so the question is, how do we keep the list updated, right? 2 ways to do it. One is there's actually a static list by many of the home community-based service providers, community-based organizations that we are curating and uploading as bulk. So immediately you have immediate value. Second is we typically ping out to the individual organization, hey, here's your information we have over the last 3 months. Is this changed or do you need to update it? So it's pretty straightforward.
Terry Mandel, BioMedLink.
I'm sorry, you want to repeat that second part? I was loving this response.
Well, my question was about how you'll
Like, to what extent your company is interested in using the information you gather about community resources to impact system-level change?
Well, it depends on really what you're saying about system level change.
Well, I mean, if your company is connecting people to the community resources they need post-hospitalization, then you have a lot of information available about what people need and then what gaps there are in the community and what people don't have access to. I mean, it's really, so essentially social determinant level data. So how do you use that to analyze what communities need and what communities should do to achieve those needs?
That's a great question, thank you. Actually, that is in our model. That is to not only gather the data that we're currently working with, as he said, with the curation of some of the data and pinging out, making sure that the data is accurate, but we're also ranking that data. And then going back and looking to the community as to what else they might need. So are there some gaps there, and how do we fill those gaps? And then actually working to create solutions for those.
So we can move up to the front. Terry Mandel, BioMedLink, strategies for collaboration in global health, including domestic health. My question has to do with a gap that exists now that's going to get much, much bigger as my generation gets older, which is between allopathic and complementary care. So pretty much so far, everybody's been talking about allopathic care, traditional healthcare delivered through various kinds of mechanisms. But there's very little, if any, integration between, the kind of care that many, many people are seeking and finding really, really good, low-cost solutions to their health problems with. And I'm wondering what you see, how technology or how the ecosystem might change to address that.
Let me respond to that. So I'd like to shift your question a little bit. So if the focus is on health, and we want to help people get and stay healthier, then we need to use whatever resources that are available at our disposal to make a difference. And each of us is different. Each person is different. In fact, we're different days. So we're motivated in different ways. And we're supported in different ways. Some people want to embrace homeopathic remedies. And others are interested in some kinds of technologies that are alternative medicine technologies. Others are interested in mindfulness, and they're interested in mind-body medicine, and massage, and yoga, and so on and so forth. So we know that there's lessons we can learn from a number of these kinds of things. I had the good fortune of being able to teach a course some years ago on the interface between Asian and Chinese medicine and Native American medicine, and some of the mechanisms that are there that some people embrace with great depth. And in my own personal life, I find a lot of spirituality and growth and cleansing through Native American traditions that I have for the past 15 years. We have to be open to embrace those different kinds of things. It's not about allopathic medicine. It's not about alternative complementary medicine. It's about what works for you and you and you and you and you. So we should be receptive to bring that into the fold.
So my question had to do with what's actually happening to facilitate that in a context of care where that perspective that you just shared is not generally.
Quick answer, Walter Reed, for dealing with PTSD, has mind-body medicine, there's yoga, they have mindfulness training and a number of other things, as an example, but go ahead.
I think to that point, I think that there are increasingly either integrated systems or payer-provider systems that are realizing that in order to really address people's health and frankly also lower the cost, that they've got to think about what kinds of benefits are they going to provide in a different way. So I can reveal that at CareMore we are thinking about as well, how would we actually expand the benefits package for many of our Medicare members to better address what it is that they're looking for to really support them in their health. So it's starting to happen. We can't say, I know, it's like this, but it's exciting, and I think, again, it's starting to open up everyone's eyes to what their possibilities are. Do we have time for one more question? Let's do one more.
Hi, I'm Amy Lee, founder of Dance for Healing. How many of you in this room knows dancing reduces risk of dementia by 76%? Yeah, and so part of the...
Dance for us?
Yeah, so this is actually a study funded by National Institute of Aging, and it's a 21-year study, walking, biking, running, dancing, golf, tennis, and listen to music, solving puzzles, reading, writing. Dancing turns out to be the highest of the activity they study, and then they're only physical activity. And I'm standing here trying to figure out how to bring up more awareness of that. I just came back from AGS annual summit. We were one of the 15 company nationwide being chosen to demo at the Tech Pavilion. And in our little banner, just this data, people walking by, and these we all talking about experts in outdoor care. They don't know. So one thing is, how do we bring up more awareness that music, dance, and art could be one of the most cost-effective way of help you guys reduce costs, help everybody, and help everybody aging happier. The other one is we do have a telehealth platform, initially inspired by my own cancer journey to address the homebound issue in cancer patients. But the behavior is very, very similar in elder care. There's a lot of people stuck at home. And what we wanted to do is bring exercise to patients' house. Being someone who didn't really have healthcare background, rather than internet technology background, I would struggle trying to figure out how do I set up or navigate through sort of this very complicated and set up as a sustainable business model so everybody can benefit from